Welcome, everybody, to another podcast for Conversations in Cardiology. My name is Frank Ng. I am one of the SCAI Associate Editors and Chief Division of the Pediatric Cardiology and Co-Director of UC Davis Pediatric Heart Center, and I'm in Sacramento. I'm honored to represent SCAI and the Editor-in-Chief, Dr. Lansky. Now, we're here today to discuss an important document published in SCAI entitled Emerging Transcatheter Devices to Assist Failing Fontan. And it's a current state-of-the-art type of paper. And I'm excited and honored to be joined by an esteemed panel of SCAI leaders and experts in this. First author of the paper, Dr. Nicola Pradegan, who is a cardiac surgeon who works out of the heart transplant and the MCS program in Padova University, Italy, is the first author. And then there are two other experts in the field, Dr. Athar Qureshi, who's the cath lab director at Texas Children's Hospital, Dr. Vivian Dimas, who's the medical director of the adult congenital heart disease at the Medical City Children's Hospital in Dallas. And both Athar and Vivian and I are sort of alumni and old friends and colleagues at Texas Children's. So again, thank you for the group for joining us today. I'm going to turn over this time to Dr. Pradegan to start the conversations. Go ahead, Dr. Pradegan.
Thank you, Dr. Range, and thank you for the opportunity to present today my review research on a very important and emerging topic. So today I will talk about the current understanding and future directions of transcatheter device to assist failing Fontan. Okay, I don't have any disclosures. So we know that heart transplantation or combined heart third lead transplantation represents the gold standard to treat end-stage Fontan patients. However, many patients with failing Fontan cannot access to heart transplantation because of a perceived impermissibly high risk of surgery to its complexity and multi-organ failure. On the other side, increasing donor shortage makes heart transplantation a very limited solution for which alternative strategies are required. So for these reasons, I aim to analyze with my co-authors the current devices which are under preclinical investigations for assisting the failing Fontan circulation and restoring a right circulation. So the first in vitro study analyzing a preclinical device was an intravascular axial flow blood pump, the figure on the left, which was a collapsible device for percutaneous positioning in the IVCA and or in the superior vena cava. The performance of this device in vitro was 2 up to 6 liters per minute with a rotational speed of 6,000 to 10,000 RPM, generating a pressure rise inside the Fontan circuit up to 20 millimeters of mercury. And this design showed a very favorable hemolysis design. This was tested both in a needleized Fontan and in a real anatomical patient-based model created with 3D reconstructions. And this was found to produce higher pressures with a low effect of blood viscosity on the design function and low probability of blood damage. The group of research of this pump then realized that given the collapsibility of the venous district, it would have been more useful to create an axial flood valve pump with a new design consisting of a catheter, protective cage of filaments, an impelled blade set, and outlet nose cap. The outer protective stand has a radially arranged filaments that serve as touchdown surface for the rotating impeller blades. The impeller rotation is generated through the drive cable fluid seal combination with a portus-clad extra solution as a lubricant and to flush the fluid seal of accumulated blood elements. And also this pump was able to increase up to 30 millimeters of mercury, the pressure inside the Fontan, for flow rates up to 5 liters per minute and rotational speed similar to the first design of the system. Another group created a new model, which was a viscous impeller pump based on the von Karman viscous pump principle. As you can see in the picture, it is represented as a smooth two-sided conical actuator disc with rotation in the vena cava axis, and the non-rotating actuator disc stabilizes the cavopulmonary flow, reducing power loss by 88%. Its driver performance gave an increasing pressure up to 20 millimeters of mercury with a flow from 0 to 5 liters per minute. And the novelty compared to the other pump is the concept of multidirectionality of flow, which increases without venous obstruction. And this is very important because in Fontan circulation, especially in the total cavopulmonary connection with the two pulmonary arteries, having a system which is able to produce a flow both in the right and the left pulmonary artery, of course, would be more advantageous in terms of function and flow generated inside the pulmonary bed. The fourth model by the Boston groups used Impella, which is a system already known and used in the clinical setting out of the Fontan, a short-term pump already used for left ventricle support. The assessment of the viability of this device for the cavopulmonary application was obtained by using a combination of experimental and numeric models of healing Fontan circulation, characterizing the local response of pressures and flows at the level of the Fontan circuit. But of course, this device was not used in vivo animal or clinical setting, but just in in vitro analysis. Left-sided microaxial pumps, such as the Impella, are not well suited for pulmonary support due to the severe flow recirculation and the need for multiple devices in the Fontan, which would be not advantageous in the fluidodynamic of the circuit. The fifth model consisted of a multi-lumen cannula inserted percutaneously coupled to a commercially available blood pump. This way, in the in vitro model, they were able to provide a pressure gain of 2 to 6 millimeters of mercury with a cannula consisting of 2 extruded discharge lumens and 1 suction lumen located in the center. This was inserted through the right internal jugular vein into the Fontan with 2 guide wires used to guide the discharge lumen nozzles toward the respective pulmonary arteries. And here again, we had a performance hemodynamic very promising with a pressure gain of 4 to 9 millimeters of mercury, but also hemolysis. To date, we found only an in vivo model in animals, specifically in an adult model of sheep, in which a percutaneous 1/2 double lumen cannula was coupled with a centrimal pump to form a cavopulmonary support system. This cannula, in this cannula, blood is withdrawn from the SVC and AVC through the drainage lumen and pumped into the right pulmonary artery through the infusion lumen, with flow adjusted to a mean of 4 liters per minute. And to prevent recirculation and perfusion of only one lung, the cannula was modified by adding a pair of membrane umbrellas on both sides of the infusion outlet. With this system at 4 liters per minute pumping flow, the Avalon light double lumen cannula returned hemodynamics and lactate to baseline levels throughout 6 hours. So in conclusion, the cavopulmonary total connection represents only a palliation, which is associated with increased morbidity and mortality at late long-term follow-up. Heart transplantation represents the gold standard. However, the donor shortage imposes the development of viable alternatives. And current mechanical blood pumps are designed and developed to support systemic circulation for adult patients with congestive heart failure. Now, the unique anatomy physiology of the cavopulmonary connection, these devices produce pressures exceeding the desired range to be used for cavopulmonary support. But in the venous system, a pressure augmentation of up to 5 millimeters of mercury probably may be sufficient to augment the energy required to drive blood flow into the cavopulmonary circulation. Of course, the development of microinvasive devices such as percutaneous pumps is mandatory to limit the surgical risks and systemic cardioembolic events, and the implementation of an ideal blood pump in the cardiopulmonary circulation should reduce systemic venous pressure, improve transpulmonary blood flow, and improve ventricular filling. And to date, there are no medical devices available to support patients who have undergone the Fontan procedure while they await donor hearts or to rehabilitate a failing Fontan circulation in order to optimize chances of heart transplantation survival, which still are very, very low. Thank you very much for the attention.
Well, thanks very much, Dr. Pradegan. I have to say, this is a fascinating paper. I don't have a lot of experience in this type of mechanical support, but I know that both Dr. Qureshi and Dr. Dimas have plenty of experience in the sort of the VAD and assist devices in their heart failure programs. So I want to just start off with a couple of questions to the panelists, and I'll come back to you, Dr. Pradegan. So to both Athar and Vivian, I know that when I first read this paper, I have to say there was a little bit of confusion as we were talking about an assist device to the systemic circulation versus the Fontan side of things, where there's not a pumping chamber. And I just want to make sure that I clarify this for the audience, especially for the ACHD physicians or those who's taking care of them who may not be as familiar with the single ventricle physiology. So to both Athar and Vivian, can you clarify this important distinction and how, in the context of these assist devices, might the two circulations impact each other when you start to use this Fontan assist device? Athar and Vivian, what do you guys think? Can you help with us?
Yeah. So I think you can't separate the circulations, unfortunately, in the single ventricle physiology. And I think that's the biggest challenge. So one thing, Athar and I worked and published papers looking at, use of the Impella, because it's really the primary thing in the US that we have to unload the systemic circulation. And I think, while failing Fontan physiology has to do with the systemic venous circulation, it's almost always intertwined with the systemic arterial circulation. And so I do think that there's utility in unloading the single ventricle and trying to reduce end diastolic pressures, atrial pressures, to enhance filling, just using the natural transpulmonary gradient from the Fontan circulation and improving output in that way. I think the one thing that has always been a challenge for getting a pump to the systemic venous side, so the Fontan side, is that you don't want to increase the pressure so significantly that you get systemic venous hypertension, because that's not a great physiologic situation for a Fontan patient, particularly one that's in Fontan failure. So I think separating the circulations is really difficult. Balancing the circulations is really difficult. But I think you'd be remiss to feel like we could just support the systemic venous side without thinking about the systemic arterial side, because I do think it's a series. And I think with a passive flow system that's dependent on the systemic ventricular system, I think you have to optimize that to improve throughput through the entire Fontan pathway. And I don't know if Athar wants to add to that.
Thank you, Frank, for the invitation. It's good to be with everybody, and Vivian, and congratulations, Dr. Pradegan, to you and your team for publishing this important paper. I agree with Vivian, and it's a very challenging situation because many of these patients, the unfortunate situation is that many of these patients who are failing Fontans already have a high Fontan pressure, and so they often have high PVR issues as well. So any increase in pressure, as Dr. Pradegan nicely summarized, I think targeting an increase of 2 to 6 millimeters of mercury. That, for the adult colleagues on the call, that may seem like a small amount, but in the context of a Fontan circulation is quite a bit. And in fact, I would argue that range is also quite large for a Fontan. And so you can get detrimental effects from raising the pressure in the Fontan circulation or augmenting flow by increasing your CBP, like Vivian said, and that can have significant effects on the on organs, on other organs in the body. And so keeping up with that and supporting the systemic circulation by whatever means, if it's medical, treating the PVR, or sometimes by implanting a device, is really important on the systemic side. So I'd like to ask Dr. Pradegan, his thoughts also, because, what is the ideal pressure increment that you see? And my sense is it's going to vary depending on what's happening to the systemic ventricle and how that is being supported.
Yeah, thank you very much for the comments and also for the question. So there are 2 points that I think must be considered. The first one is the limitations of the in vitro analysis, because of course, even if you try to create a model which is anatomically similar to a Fontan patient, by the end, it is not just a matter of the anatomy of the pulmonary arteries, but it's also a matter of how many collaterals you have in the lungs, how the bed, the microcirculation of the lung is, and second, most important, how the systemic ventricle is functioning, which kind of anatomy you have, if you have a right ventricle or a left ventricle as a univentricular ventricle. We know that right ventricles usually have a worse function and worse outcome. So these are points which must ruled out when you try to create a similar device. To answer to your question, I don't think that we can answer to your question because we still do not know which might be the best increase of pressure inside the Fontan circulation, because you should consider from how much time the patient was, for example, on the Fontan circulation, and also the characteristic of the anatomy. But the point is that, and the idea for which we hypothesized also this review, was that we should consider to create or to have a device, a percutaneous device, which is able to restore the pulsatility of the flow in a system which does not have pulsatility, in order to retrain the systemic venous circulation and the pulmonary circulation to accept in a secondary time, for example, an heart transplantation, and see if with this sort of percutaneous retraining of the right sections, you can have a better outcome at the time of heart transplantation.
Well, thank you for that. Actually, I think as the panelists correctly pointed out, that in a single ventricle physiology, the 2 circulations are intricately tied. And so the question to Nicola is, at this time, of the devices that you've shown us, which one do you think that might hold the most promise for clinical trials? And that's the first question. And for the ones that you've worked on, do you find that most of these patients require a Fontan assist device as well as the assist device on the systemic ventricle side, where one is pushing, the other is pulling? And so, what do you can you comment on that?
Yeah, so very hard question, because as I told before, we are just speculating on in vitro systems. I think that the third model, the one with the possibility of promoting the flow in both directions, and granting the multidirectionality of flow, might be useful to get a better perfusion of the lungs. But of course, the limitation of in vitro studies should be managed with in vivo studies in animals with all these devices. Probably this is the time to understand how this works in Fontan models. Regarding the possibility of using systemic devices for the univentricular dysfunction ventricle, the percentage of failing Fontan with systolic dysfunction of the single ventricle are not the 100% of the patients. So probably we should consider the use of this device in those patients who do not present systolic ventricular dysfunction and consequently pulmonary hypertension secondary to the dysfunction of the ventricle.
Okay, I'm going to add another question. We know that the CardioMEMS is a novel device, at least in the pediatric world, right? In the adult side, that's being used more frequently, and I have seen more and more institutions sort of trying to adapt that to the pediatric side. And so how might this technology be integrated into the Fontan, the failing Fontan? And again, this is sort of a question, open discussion for all three of you guys. Have you guys thought about how that might actually be also part of the application for the failing Fontan, where you can remotely monitor PA pressures and time when the assist devices can be placed and so forth?
You know, when you have these patients and they're failing, they tend to come to the cath lab, Frank, right? We get baseline hemodynamics, and it's a great opportunity to potentially place the monitoring device. I think the primary issue with CardioMEMS, at least in my opinion, has been one, it's, you know, you have to lay supine and you sort of do these spot checks. It's not a real reflection of what you are like when you're active, although there is a new device out in the adult side that looks at that. But then the second thing is, with these low Fontan pressures that vary only over 1 to 2 millimeters of mercury, how sensitive and predictive is that going to be? And I think Athar should talk about their experience, because they've been implanting them, and he can speak a little bit more to what they feel like they found from those monitorings.
Yes, I agree with Vivian. I think there are challenges. I think, you know, we've been implanting them here, and I know that other institutions have. There's actually some published literature out there and some more literature that will be coming out. So the challenges in a Fontan are a number. One is this is a passive circulation, so it's not pulsatile. But to Dr. Pradegan's point, maybe when you put a VAD, ventricular, or an assist device in the Fontan circulation, maybe that will improve the accuracy of CardioMEMS. Time will tell. But the challenge right now in a Fontan is that, first of all, it was not designed to measure passive circulation, pulmonary artery pressures in a passive circulation. And secondly, thrombosis risk. So there was a recent paper, I believe it was published by Kurt Daniels and his group from in Ohio, and they looked at a number of patients, and there was 1 or 2 patients, I believe, had thrombosis. And again, this is a passive circulation. It's not like the usual adult with heart failure. So that's one concern. So how does the device, CardioMEMS, what are the risks of thrombosis in a Fontan circulation? And we already know these patients are predisposed to thrombosis. And secondly, as Vivian correctly mentioned, the accuracy, you know, a few millimeters off here and there can make the difference in terms of how we treat these patients. And in our experience, and Kurt Daniels' experience and others' experience, there are not an insignificant number of patients who actually, when you bring them to the cath lab to look at the correlation, they're actually not correlating to our liking. But again, maybe with the assist devices that Dr. Pradegan is proposing, maybe that might improve the accuracy of CardioMEMS in this situation. I guess time will tell.
Thank you for the discussion. I know we're running a little over time, but I have one more question, which is more of a technical question. When you put these devices in, are you still able to bring the patient back to the cath lab and run catheters past these devices to actually do hemodynamics and just follow-up assessment?
Yeah, this is a very smart question. Actually, in these in vitro tests, they did not evaluate this concern, but for sure, in the setting of creating a similar device, they will be able to consider also this aspect, because the evaluation during follow-up of the pressure in the circuit is mandatory, and during the procedure of creation of a device, they will for sure consider this analysis.
Great. Well, I know we're way past the time for the 15 minutes. So again, I want to thank everybody for taking time to have this fascinating discussion. Thank you very much.